Okay, welcome everybody. A warm welcome to everyone to this colloquium today. I know that it's a full, busy program with all kind of lectures today, but very glad to see you all here. Thanks for coming. Also online, people, can you hear us online? Can you please maybe put something in the chat? Yeah, thumbs up. Good, great. So today I would like to introduce Hidde van der Ploeg. Some of you may know him because he's been around for quite a while here at VU, at least at the Amsterdam University Hospital. Hidde is an associate professor at the Department of Public and Occupational Health. And I just found out the great news that we have a very fresh professor because he will be a full professor as of next week, right?
Monday.
On Monday. Congratulations on that. So very happy to hear your expertise on physical activity, sedentary behavior. You've been involved in several guidelines on physical activity and sedentary behavior, and mainly in the occupational health, but also more in public health in general. So I think we as human movement scientists all sitting here passively listening to your presentation can learn a lot from that. So
yeah. Thank you very much. Thank you for having me, coming back to where I once studied. And you're actually in my department at the moment because our department became that corridor and that corridor. So it's sort of a home game and then coming home. I don't know. All right, so I work at the Department of Public and Occupational Health of the hospital in the section Health, Behavior and Prevention. And our team is about 40-50 people with people with backgrounds in nutrition, or physical activity, obviously, smoking, but also system science, policy evaluation, and implementation science. So quite a broad group. And I'm going to give you a bit of a taster of the work we do on physical activity and sedentary behavior in regard to public health. Feel free to ask any questions during. I've got about 56 slides or something, so that's a lot for the hour, so we'll see how we go, but I can skip a few things if it takes too long, so don't hesitate to ask questions, and some of them will go rather quickly. Well, let's see where we end up. All right, well. Good, so what I'll talk about is about physical activity and sedentary behavior, and I'll explain the difference in a minute. Very briefly around this little bit of definitions, a lot about the health benefits and the epidemiology, which then leads into the guidelines and the recommendations, a little bit around prevalence, so how much do we actually do these things, and I'll talk about strategies to improve both behaviors and some of the intervention work we've been doing towards the end as well. All right. So dimensions of physical activity. You probably work in physical activity and probably a bit more towards sports or exercise. And it's good to realize that that is just a small portion of all physical activity, right? So when we talk about physical activity, I'm talking about the bigger picture, of which, of course, sports and exercise is a very important and enjoyable part, but it's only part of it. And that means it's also only a part of the solution. Okay, but I'll get back to that in a minute. So quickly, the dimensions. I've got a separate slide on domains and types. One on intensity. I'll talk about that shortly. Then, of course, there's the duration and there's the frequency. Now, if we talk about domains, we're talking about doing physical activity during occupation or during education, transportation, household and leisure. And you see all these things nicely come back in the little picture with people doing some leisure in the gym, some transportation, and then there's a dog walking man behind the Zoom at the top, which is probably household, or if it's a professional dog walker, it could be occupation. So covers everything a little bit. All right, so everything we do while we are awake, and I really want to talk about the time that we're awake because sleep has a different association with our health. And I don't want to talk too much about that, but you can sleep too much, you can sleep too little. But everything we do when we're awake can be divided into these four intensity categories. Sedentary time, which I'll talk about a bit more later, light intensity, moderate and vigorous, and you see the metabolic equivalence behind that. So that's the amount of energy you spend on these different intensities. And free mets means you're doing 3 times as much as your basal metabolic rate. When we talk about health enhancing physical activity, traditionally we've been talking about moderate to vigorous. And walking and cycling for transport would be around 3 mets, and that would be in the moderate intensity. And the guidelines you see traditionally have been around moderate and vigorous. But I'll talk about the other two as well. All right, so the global burn, oh, I should stay there because the microphone. You're over there, right? Or over here? Yeah. Sorry. Okay, I can walk around. I like to walk around because you're all sitting and I'm walking around. All right, so the burden of physical inactivity. This is from the Lancet special issue on physical activity from 2012, where they looked at smoking compared to inactivity. And inactivity is defined in this case by people who would not meet the recommendations for physical activity from the World Health Organization. What those are, I'll show you later. Around 26% of all adults worldwide were smoking at time of this calculation, and about 35% of people were inactive. Now, if we look at the risk for all-cause mortality for smoking, that's 1.57. For inactivity, that's a little bit lower, it's 1.28. If we combine those numbers, we get the population attributable risk. And these numbers mean that roughly 9% for smoking and inactivity, all deaths worldwide could have been, 9% of all deaths could have been prevented if nobody was smoking or nobody was inactive. And you see the numbers are really quite similar. And they're the combination of these two. So smoking is worse for you, but less people smoke than that people are inactive. And we're talking about roughly 5 million deaths per year. So from a public health point of view, physical inactivity and smoking seem to be quite similar on the world stage. All right, next slide. Here you see the risk of all-cause mortality in the y-axis, and on the x-axis you see physical activity. These people are doing no physical activity, and then the second group is doing a little, and it just goes. And you see, and that's the most important thing that strikes me here, is that the biggest gain for the risk reduction of all-cause mortality is between doing nothing to doing a little bit. Yeah, go ahead.
Probably this is correct, but isn't this because the only reason to be completely inactive is to be sick?
The correctness analysis for people who actually have to see. Yeah, good question. But the point, I think, is that from a public health point of view, the biggest health gains can be gained by making the people who are doing nothing to making sure they're doing a little bit. And there's additional benefits if you keep doing more, but it levels off a little bit. Yeah. All right, this is the list of all the health benefits that the 2018 US physical activity guidelines thought had enough evidence. And in bold, you see the ones that were added compared to the guidelines they had previously. So those things were added because the evidence had accumulated more over time. So a very long list. I talked about all-cause mortality at the top. Cardiometabolic, so cardiovascular disease, type 2 diabetes, a whole list of different forms of cancer, brain health, so improved cognition, quality of life, sleep, obviously weight. So the combination, I think, of physical activity and diet, but physical activity does play an important role there as well. And then for older adults, the risk around falls, but also physical function. And the latter is probably important because it's sort of a vicious circle where people do less physical activity, their participation goes down, loneliness can come in. So it's a different one than the others because the other ones are all related to health. The last one's really around physical function. But a very long list, and they concluded that physical activity what's the best balance for public health? So one of the things we should probably put our money on and make sure that things actually change. I'm probably preaching to the converted, but it's nice to have some common ground as well. All right, so on to the guidelines from the World Health Organization from 2020. This little slide, I think, nicely shows you that the picture I showed you before, the biggest gains from doing nothing to doing a little bit, it levels off. And then here you see the risks and harms, and there's very little risks in doing a little bit moderate intensity activity, and the risk goes up if it becomes more vigorous or if you do contact sports, etc. It's a little bit of a simplification, but you do get a sense of how these things are related. One of the conclusions from the 2020 guidelines was also that doing some physical activity is better than none. And this is the first part of the recommendation before they actually put a number on it. But we'll get there a bit more detail when we talk about sedentary behavior, but it's an important message. So it's not just reaching a certain target, but basically all physical activity matters. So these are the guidelines for adults. You see here that, should I put the camera, because I'm just walking out, right? So you can actually see me. All right, here you see for adults, so this is not a surprise and you're probably all aware of this, but somewhere between 150 to 300 minutes of moderate to vigorous physical activity per week is the recommendation. Your vigorous activity counts double. So this is moderate, this is vigorous, and in theory, doing half the amount of vigorous would give you similar effect as doing twice the amount of moderate. Does that make sense? And the combination of that adds up. That doesn't mean that there's no benefits above 300 minutes or the 150 minutes of vigorous. There is. And doing more is probably better. Just as being more intensely physically active is usually better. But this is a public health recommendation, and getting people to do a little bit is already a challenge, and I'll show you how challenging that is in a minute as well. Then there are the recommendations around muscle strengthening activities, which should be done twice per week. It's not more specific than this, so there's nothing about repetitions or durations. This is it, okay? But basically they're saying that some strengthening activities, maybe as part of that part of the spectrum, is also important. And the same is true for all the people around functional balance and strength activities. Then for kids, the recommendation has changed a little bit because it used to be 60 minutes on every day of the week. Now it's 60 minutes on average. So that means you could do everything on one day and don't do anything of the rest of the week, and you would still meet the recommendation. Before, it really had to be at least 60 on every day. For surveillance, you can imagine that it makes a huge difference in how you can measure that of the population and how you can look at the time trends on it. So that was not good news for it was good news for communication, but not for surveillance. Pick up?
Just the doing a little bit is already so beneficial. Why don't the guidelines follow that?
Sorry?
If the doing a little bit is already so much beneficial, why don't the guidelines follow that?
Yeah. The guidelines basically put a target that's reasonably achievable for a large part of the population, but that doesn't mean that if you are below, so if you do 150 minutes or 149 minutes, the effect is the same, right? But that doesn't really matter. And the guidelines do say that some physical activity is better than none, and you should try to do as much as you can. And they don't just say 150 minutes, but 150 to 300 minutes. They try to put you in a certain range where we know that the health benefits are really good, even though there's more here and there's some below as well. So it's a public health message. It's not an exact number, but suddenly everything changes. right? It's more continuous, and the biggest gain is from the beginning to doing a little bit. Does that make sense?
Yeah, although I can imagine that people may, on a population basis, get demotivated because they cannot achieve the moderate intensity.
Yeah.
Even though, if they do just a little bit more in terms of hours, low intensity, they already achieve quite a benefit.
Yeah, and that's why I think it's important that doing something is better than none. Message gets out more in the communication part, because it is part of the recommendation, even though the second part sort of gives you that range to give you a bit more guidance and a target where to be.
May I ask a related question?
Yeah, sure.
Yeah, so I've always wondered how these magical numbers came to be. So why these thresholds at 150 and 60? Can you shed some light on that?
Do we have an extra hour? No, so most of this is based on epidemiological data. So the prospective cohorts where people were asked to fill in a questionnaire. We now also have data from activity trackers, but there wasn't much around when we did the 2020 guidelines. And they followed people until they got sick or they died. And from those questionnaires, and I'm not sure if you ever use physical activity questionnaires, but there's a lot of variation between the questionnaires as well. These numbers came out. And the funny thing is that now that we have some data with the activity trackers, the 150 minutes doesn't seem to be that bad. So the target isn't as different now that we have a more objective way to measure.
It suggests sort of a discrete threshold that if you
Yeah.
surpass it,
Yeah.
then you're in the good. And
Yeah, and I think they try to move away from that with these guidelines, with messages such that every move counts, doing something is better than doing nothing. But still, and that's why they also put in a range rather than one threshold where suddenly life would change and sunny and So in that sense, but you got a point. On the other hand, if you look at this part of the guideline, say do 2 times a day strengthening activity, people don't understand what to do with that.
No.
Because, okay, I did my strength now, or how long is it? So you somehow need to be specific, and it has to be an easy message at the same time. So it's complicated, but it's one of the things I think it's a good point. All right. And then for kids, we went from 2 days, 2 times a week strengthening to 3 times a week. I'm not going to comment much on that. All right. So, and this probably relates nicely to your question, Siko, around what about people getting discouraged? These are the guidelines for people living with a disability. There are similar guidelines from the WHO for people living with chronic disease and pregnant women as well. I don't want to go through all of those, but here you see that for people living with a disability, the guidelines are exactly the same. So this is what you've seen in the previous 2 slides. They do have these best practice statements. And you see, it starts with doing sorry. Line, could you mute yourself? Or,
Thomas, ik kan jou niet muten. Kan je jezelf muten?
Thomas, could you mute yourself, please?
dat was het einde van Thomas.
I think we're good again, right? All right. And I think this part is sort of encouraging people not to be discouraged, but rather to look at it indeed more as a, try to do what you can within your own capacity, try to find things that actually match with your life that you can do for a long time. So I think in this way, they've tried to make it more inclusive one, because there weren't any guidelines specifically for people with a disability, and at the same time make the communication easier. Yeah. These are the guidelines from the Netherlands. I'm sorry, these are in Dutch from 2017, and they're actually quite similar. But I did, since we are in the Netherlands, briefly wanted to show that. All right, so how active are we, right? So this is data from the National Institute for the Environment and Public Health. And you can see that less than half of the Dutch adults actually meet these physical activity guidelines. Less than half. And you also see that the line is rather flat with a very strange corona bump where we're not really sure what's happened there, but could be something to do with response bias, or there may be actually something changed. But we're back where we were. And we also see that we've struggled to actually make much of an impact on the population levels. Well, we can have a very long talk about why that is, but I want to move on and just briefly show you this slide. Here you see education level with the people with the least education and the most, and you see there's quite a gap there as well. And we see that gap, of course, in nutrition, in smoking, and the clustering of unhealthy behaviors on people with less education. All right, now I want to go back to my slide with the intensities. And I want to add this. 150 minutes at least of that moderate to vigorous physical activity. If you sleep 8 hours in the night, you are awake for 16. You only have to be physically active at a moderate or vigorous intensity for 2% of the time. That's nothing, right? And still less than half than the people are struggling to do this. So it's really, no, they're not lazy bastards, Joe. It's difficult. It's difficult, right? So we've made our lives so incredibly comfortable that you can all sit here in very cushion-like chairs and be comfortable, and you can spend your whole day like this. Do no physical activity. And a lot of people are actually not doing it. It also means that there's still 98% of the rest of the day left if you meet the recommendation. What about that part of the day? And surely it matters what you are doing in that 90% of the day. So, I want to talk about sedentary behavior, and sedentary behavior is defined as any waking behavior again. So we're not talking about sleep time with low energy expenditure, and basically we're sitting down or reclining or in a lying posture. This is not the same as inactivity. And I'll show you why. You know Homer Simpson, he drives to work in the morning, works really hard during the day, drives back home, and then he spends his evening with the family on the couch watching television. It's a bit old school, there's no tablets yet. This is a sedentary day because he sat all day. Is it an active day? Yes, because it's a trick question. Because he went running for 30 minutes. If you divide 150 by 7, it's about 21 minutes per day that you need to be physically active to meet the recommendation. So he met the guidelines, but he was sedentary for the rest of the day. Can you also be inactive, but not sedentary? Yeah, how?
Garden? Garden?
Gardening, yeah. What, you garden all day or?
Gardening counts as street work.
Yeah, exactly. Yeah, so people who have a job where they're up on their feet all day, like a gardener indeed. And gardening probably has some moderate and maybe even vigorous, depending on what you're doing. But people with, for example, work in a store, or people who are hairdressers or something, they're up and about, so they're not sedentary because they're not sitting down, but they're not doing any moderate intensity activity necessarily during their job either. So it is possible to have people who are inactive and not sedentary. So my point here is, of course, that inactivity and sedentariness are different things. And they probably operate on different time scales. Because for 21 minutes per day, moderate to vigorous, I'm already really happy. And sedentary is hours and hours. And how sedentary are we then? Well, also around 9 hours of sitting per day. And this data has only been collected since 2050, so it's a little bit more recent when they started using the sedentary behavior questionnaires at Erifia. And it's a flat line as well. But there you see that how they operate on different time scales. Interestingly, I put in the education slide here as well. It's reversed. So the high educated people are the ones with the poorer health behavior in this case, because they sit more. Well, I don't have to explain you why, right? Lots of desk jobs and not blue collar jobs, for example. Okay, so what? What about this sedentary time? So this is a study in Australia, the 45 and up study, where we have over 200,000 people. And if you look at the green part in the front, you see the physical activity, you see sitting time, and here you see all-cause mortality. And in the green part, you see the same as I showed you in the beginning, that the biggest gain for doing no physical activity to a little bit has the biggest risk reduction in all-cause mortality. Then it levels off. If you look in the other direction, you see that there also seems to be a relationship with sedentary time. And the biggest risks are for the people who sit the most and who are doing no physical activity. So 13.5 at the top. Well, this study was one that was also included in a meta-analysis, which was then published in the Lancet Special Issue from 2016. And I'm going to talk you through this. Here we see the all-cause mortality risk. Here we see sitting time, 8 to 10, more than 10 hours a day. And the colors are different levels of physical activity. So the red group is the least physically active group, and the green one is the most physically active group. Now, if we only look at the first part of the graph, so up to around 8 hours of sitting time per day, you see the same as we've seen before. The least physically active group has the highest risk, and there's the biggest reduction to the second group, and then a little bit after that. Nothing new. You also see that the lines are all flat in this part of the graph, meaning that the effect of sedentary behavior doesn't seem to contribute. The second part of the graph shows a very different picture. So suddenly, in the least physically active group, the risk goes up with the amount of sedentary time. In the most physically active group, there's no difference anymore. Okay, so if you do enough physical activity, moderate to vigorous, you can compensate for sitting the rest of the day. Well, that's good news, because you sit a lot of the day and you probably do lots of sports in the weekend. But this group is doing more than 45.5 meta hours of physical activity per week. The guidelines, 150 minutes per week, translates to 7.5 meta hours per week. So these people are doing 5 times as much as the guidelines prescribe them. We also saw that less than half of the people already meet the guidelines, let alone 5 times the guidelines. So yes, you can compensate by doing more moderate to vigorous. You have to do a lot of it. This is a similar slide. The previous slide was on all-cause mortality. This is cardiovascular disease mortality. And the only interesting difference here, it's a very similar pictures, but that for the least physically active group, the risk seems to be going up from the start. Yeah. So maybe, well, the guidelines don't, I'll talk about the guidelines, I'll come back to this. But maybe the difference between different health outcomes will show you different dose response effects. So maybe the cutoff where we say, okay, you shouldn't be more sedentary than this amount of time varies depending on what health outcome you're looking at. That's sort of what this is suggesting. All right, so conclusions for the US guidelines before we move on to the actual guidelines. At the time in 2018, there was enough scientific evidence that sedentary behaviors relate to all-cause mortality, which I showed you, and CVD mortality, which I also showed you, but also for cardiovascular disease incidence, type 2 diabetes incidence, and a number of different cancers. A much smaller list than you saw for physical activity. But remember, this is quite new. We always were focused on moderate to vigorous physical activity. And the research around sedentary behavior has only been accumulating over the past, I don't know, 15 years or something. Okay, so what are the guidelines when it comes to sedentary behavior? So this was included in the 2020 guidelines, and it says limit the amount of time spent sedentary. Well, there you go. This is much more fluid, but what does it mean, right? There's no number that you actually have that helps you understand where to be. It also means that at the time they weren't sure whether there actually was sort of a threshold or a range. The Canadians have since included an actual number or a threshold in their guideline, which is around 8 hours. They would show at the time thought it was too early to do that. When they come with the new guidelines in 2030, I'm guessing there will be a number on that, but we'll have to wait and see. But you see that this is quite accurate, but it also is more difficult to communicate, right? Because you don't really know what it means. And the funny thing is that once we saw the first evidence around this and we started doing intervention around it, that people suddenly thought that they shouldn't sit at all anymore. And that sort of overreaction, I did not expect, because it's sort of, well, you think like, okay, it's probably the too much that's the problem and not the sitting in itself, because sitting is a natural behavior. It's comfortable, you feel very rested. You shouldn't completely abandon it, but some people threw it out of the window immediately and only wanted to stand. So, but I'll talk about standing in a little bit. All right. So that also means that the guidelines with all the thresholds that we had before sort of become more of a palette around the whole spectrum of physical activity, from sedentary behavior all the way to vigorous, where we want to be in the green, and there's different ways to start to come to the green, right? So here's your physical activity, here's your sedentary time, and you want to stay away from the red, but there's different pathways of getting to the green. So either reduce your sedentary time or increase your physical moderate to vigorous physical activity. And it's more that interaction that we're moving towards. That also makes the communication more difficult, where we had 150 to 300 minutes, but how much sedentary behavior am I then allowed to do? Well, there's no recommendations on that yet. And we'll see in the future if there will be, and how they can make that in an easy way to communicate that. So it's a clear message, and it doesn't become a crazy computational thing where you have to put in different numbers and then suddenly a magic number comes out, you should do this or that. Because, well, the guidelines are pretty straightforward and understandable at the moment.
There's also a spread of these things over time.
What do you mean?
Well, when do you do what?
Yeah, certainly. The other part of the recommendation is, what if we limit our sitting, then what are we doing then? And remember that intensity slide I showed you, 98% of the time we spend, if we just meet the guidelines, spend sedentary or in light physical activity. So the light physical activity is it's almost the other side of the coin. Because 98% of the time is in either one of those. So if you're not sedentary, you're spending it in light intensity activity. So right now, I'm in light intensity activity. Sorry, you're in sedentary. Yeah, but it means that replacement is by light and maybe a little bit by moderate and vigorous, but I'll come back to that as well. Actually, I'm coming to that now. All right, so this is a theoretical bit where we have somebody that's awake for 16 hours, sleeps for 8, is sedentary for 11 hours a day, and doing light intensity activity for 5. No moderate to vigorous. If we get that person to do half an hour of moderate to vigorous physical activity, a bit in green, great, right? We are meeting more than the guidelines. We saw the health benefits, and this is incredibly difficult to achieve. In our interventions, if we get from 0 to 30 minutes a day, the champagne pops open. So very difficult. At the same time, Oh, hold on. Yeah, so the biggest gain is there from doing nothing to that, doing that half hour. At the same time, a reduction in sedentary time, the replacement of sedentary time with moderate to vigorous, is also half an hour. But we went from 11 to 10 and a half. And there we see how they operate on different time scales, and where the huge gain we find in moderate to vigorous physical activity and the health benefits associated with that only leads to a kind of smallish reduction in sedentary time. So that means if we want to really focus on reducing our sedentary time, we need to focus on the light intensity activity.
And not to mention compensation in your previous slide, because compensation behavior, if you think I've been active for half an hour a day, I can be sitting 2 hours more.
Yeah. And ideally, we want to do this, right? So reduce that sedentary behavior by doing more light and meet that physical activity recommendation. And in intervention work, that is also means we have to target different things. Because right now in our first studies where we asked people to reduce their sedentary time and increase their physical activity, most of our participants thought, well, I went walking for 20 minutes now daily. Great, and we were very excited about that. They also thought, I reduced my sedentary time by 20 minutes. I'm done, but they never really understood that the 20 minutes reduction in sedentary time wasn't going to make the difference in the huge amount they were being sedentary. And you need to frame that in a different way if you really want to make an impact there. So it requires different kinds of attention in your interventions. All right. So that was the theory of how to increase physical activity and how to reduce sedentary time. Now I'm going to give you a few examples of what the World Health Organization has recommended as the 8 best investments for physical activity, and then move on to some examples of interventions we've done. So the 8 best investments for physical activity, this sort of comes back to the very first slide I had where I said exercise and sport is only a part of physical activity. It's much broader than that, and you'll see that here. So if we want to increase physical activity, programs that are focused on schools are a good start. Focus on active transportation, which we are very good at in the Netherlands. Urban design, which is obviously related to transportation as well, but the infrastructure around physical activity and the way we set up our transportation system, places to walk to, places to be physically active, to play sports, it's all very important to have the opportunity at least. It's definitely not the only thing, because we live in a country which really has a very good infrastructure around walking and cycling, and lots of walking and cycling for transportation, but still less than half of our adults meet the recommendations. So a good environment is sort of a starting point, but to make sure that everybody uses that environment is still an extra step. And well, how to get there is complicated. The healthcare setting, there's lots of initiatives around lifestyle medicine at the moment in the hospital, around primary care, and we see that there's an increased intention around that. And that's definitely one of the 8 best investments as well. Public education, mass media, sports and recreation, of course, the workplace, and then community-wide programs, or much bigger programs in parts of the city, for example. So those are the 8 best investments, and now it's going to get a little bit more tricky, because I have to show you a little movie. Kun jij nog zien? Ja. Okay, so this movie is about the Eurofit intervention that we did. And the video sort of speaks for itself, but I'll talk about the research that we did on it after that in a few slides. But it gives you a good sense of what the intervention was about, what the people were, and what we were trying to do.
We are all aware of the positive impact that a healthy diet and regular physical activity can have on our lives. We also know that remaining fully committed to a healthy lifestyle is often not an easy task. What if the football club you're passionate about could lend a helping hand?
If your wife tells you to go to the doctor, you go, no, but if your football club tells you to go to the doctor, you go to the doctor.
En na controle kan je niet houden. Maar dan was het aan het niet.
Omdat ik purpose, de eerste. Dan wil ik wat, ja, met z'n allen wat onderbreken.
This is the premise behind Eurofit, a program that encourages sustainable changes in diet, physical activity, and sedentary time in a large number of football fans across Europe. Eurofit is a research study funded by the European Union. It brings together scientists, public health experts, private companies, 15 professional football clubs, and most importantly, their fans. Elite clubs from Norway, the UK, the Netherlands, and Portugal start by recruiting a large sample of volunteers from their huge fan bases. Next, coaches from the clubs provide these participants with guidance and a variety of tools for behavioral change based on the best scientific research. The program goes on for 12 high-spirited sessions with fun, camaraderie, and a willingness to learn and improve are always present. With Eurofit, participants have a unique experience. The club they've cheered for since they were little invites them back into their stadium, this time to help change their lives for the better, with the same team spirit and enthusiasm as ever.
Ik dacht na today's town and there, that's how it made me feel.
Dan moet ik wel een lokaal fantastisch. Je kan zien dat nu waar muitas coisas mesmo. Algumas coisas que eu ganhei, algumas coisas que eu fiz more steps throughout the day, and also stand nothing. Eu para que nós usamos depois obrigado a estar até para mais vezes durante o dia. Foi hábito bom que se criou. Altijd zal het niet sport geweest, maar voor de tijd dat ik op ga denken aan mijn gezondheid. Dus ja, ik denk een groep wat gelijk stand, ja, misschien niet rond. Maar mij wel zeker geen lijst. Ik heb het al in mijn gevonden geen lijst. Ik recommend it anyway.
With 30 million fans all over Europe, it's hard to overstate the power of football, especially for men. In Eurofit, our goal is to channel that power towards a more healthy, active, and happy Europe.
All right, so that was Eurofit. And the video already told you that we did a study around this as well. But I think you got a good sense of the intervention itself. Why do you think it potentially could be effective?
Absolutely, the intrinsic motivation of the participants, I would say.
Mm-hmm. Yeah. Anybody else?
Social aspect, bonding with the club.
Yeah.
Social interaction.
Yeah, social interaction. This was actually fun to do, right? So you weren't just you weren't working really hard to work on your health. You were actually doing something fun, and at the same time, you were working on your health. So maintenance-wise, that's much easier to maintain over time than going to the gym and wreck yourself there because you really need to. Right? Okay. So we did the study. We had all these clubs in the Netherlands, England, Portugal, and Norway. Men were 30 to 65, BMI over 27. They had to pass the PARQ plus, so they didn't have any reasons not to participate in the physical activity. Borrel komt eraan. They were not supposed to participate in any other program, and they had to provide us with activity tracker data for at least 4 days at baseline, because that was our primary outcome. So we assessed over 3,000 people for eligibility and ended up randomizing 1,100. I'm not sure if you've ever done a trial like this, but usually getting 1,100 people is hard work, and it always takes much longer than you want. Not in this case. This is probably the only study where recruitment was easy. We had that one Dutch club where on Friday we set out advertised the study on social media, and on Monday morning when we opened our email, we had twice as many applications as we could handle. We had to quickly close the study. So a refreshing recruitment story for a change instead of all the scraping that we do otherwise. You also see the reasons people did not participate, and part of that reason, because we couldn't approach them or reach them, was exactly because we had too many people that we could actually handle. The other reason is that people with a BMI, the other big reason was that people with BMI under 27 also want to participate, which is what we usually see in these kinds of studies. We usually attract people who are actually already kind of healthy and active, but very excited about the study, but not the ones that are in the high risk group that we really want to target. And some screening at the beginning is clearly important, because otherwise, even if you tell them you need to have a BMI of 27, still a lot of people apply that do not have that. All right, then we randomized them into 2 different groups, and you can see that we were quite happy. Yeah, go ahead. Yeah. And then you see our post-program measurements, a 12-month measurement, and this is the number for the primary analysis that we did, and we lost quite a small portion of the people. So usually these kinds of trials, we hope to lose less than 20%, and we easily made it in this one. So there was a lot of excitement to stay in the study and actually show for the measurements. They had to we drew their blood as well. They had to come to the stadium, but that was actually something that probably was a benefit for them rather than a burden. Average age was 45, but I really want to focus on the number of years of education. The other things in these kinds of trials, besides that we tend to over-recruit active people if we're not careful, is that we tend to over-recruit high educated people. In this case, we have a much better spread than we usually see. Still, the higher educated are overrepresented, but the spread is there. It's really across the education level, which is good. In this slide, you see the attendance to the different sessions. Each line is a club, and they could have a maximum of 12 sessions. This is average over all the participants in that club. In orange, of course, you see the Dutch, and we were kind of proud that we have the highest of all the 4 countries, but I shouldn't gloat too much. And you see that attendance was really quite good. The other thing is that we asked them to score. We always do mixed methods in these kinds of studies, so we do all the quantitative data, but also qualitative. And one of the things that they had to rate, give a report card 0 to 10, or 1 to 10, excuse me, on the program. They scored an 8.8, and they scored their coach a 9.2. So, like I said, so much excitement amongst the participants, and you see that in the numbers, reflected in the numbers as well. All right, then on to the actual outcomes. Our primary outcome was around steps taken, assessed with the active pole accelerometer, and sedentary time, which obviously I talked about before. You see that we had a nice increase in the intervention group, which is in orange, compared to the comparison group, which is in red. of 1,200 steps per day, and that effect probably halved almost at 1 year. So we often see that short-term behavior change is not so hard. It's the maintenance where people often drop back to their baseline, which is a bit more of a struggle. Here we still had about half, so we were reasonably happy with that. On the other hand, these were our results also from the active poll on sitting time. So there was a reduction of a little bit under 15 minutes per day, and that effect was basically gone at 1 year. So this was one of those interventions where we realized that people did not really understand the sedentary behavior message, because they were doing more physical activity and thought, I'm doing more physical activity, so I'm reducing my sedentary time. And this is one of those studies where we thought, okay, we really need to put extra focus on this, even though they had the tracker where they track their steps, like, you know, some of you will have your Fitbits or your Garmin's, etc. The tracker also told them how much time they had been sitting down. So it's a new number. Your tracker doesn't actually do that because you have to wear it in your pocket to assess that properly. But we try to give them real-time feedback on their sedentary time as well. But we were not very successful, or at least not as successful as we hoped we would be. The intervention, of course, was focused on physical activity, sedentary behavior, but also on diet. And here you see some of those results. So they improved quite nicely on the fatty food score, and they managed to maintain that. The sugary food score, similar, they did well, and they dropped just a little bit. Fruit and vegetables went up and kind of remained a little bit as well. And alcohol consumption went down and actually was even better at 12 months than directly after the intervention. We also looked at their body weight, and they reduced their body weight by 2.5 kilos, and they managed to maintain that after a year as well. So 2.5 kilos in this kind of intervention makes me excited. If you look at how high they were already, and then 2.5, maybe you're like, okay, it's only a little blip, but don't rain on my parade, okay? Another thing I think, and you saw that probably in the little video as well, is that even though we focused on their physical activity, sedentary behavior, and diet, their overall well-being, it was bigger than health for them, right? It was a fun thing to do. They made new mates, and you know they improved in lots of other parts of their lives as well. And we see that nicely with the well-being. They scored themselves around a 7 at baseline and about a 7.5 at follow-up, and they managed to maintain that as well. So to conclude, physical activity and diet we were effective in changing their physical activity at 12 months. That led to reductions in their body weight, also the biomarkers, which I didn't show for the sake of time, and their well-being. We were not effective in changing their sedentary behavior. And this is a nice before-after picture. That, you know, if you've actually been there, it's sort of goosebumps where you see how people really turn things around. So what then? We had a nice intervention, which was effective. We managed to recruit people, but what now? How to implement this into actual practice? How to roll this out? And this is something that is more and more entrenched in our research, where we really look at the next steps and how can we make things land in practice, because the gap between science and practice is really still quite big, even though we've all been trying to make it smaller. One of the things we did was register the intervention in the database Gezond Leven from RIVM. And you see that at the moment we're the only intervention. There's a few hundred, I think, in there, but the only one on the highest level of evidence in the overweight category. So you'd think, okay, great, you know, this is the national database intervention. You've done well. You got an effect, highest level of evidence. everybody's going to use it. No, it's much more complicated than that. So at the moment, and we are already a few years after the intervention, we have a few clubs that were in the trial and a few clubs that were not in the trial that are still running things that are quite reasonably overlapping with the Eurofit thing. Yeah, the original program. The league, the Eredivisie, is actively involved and working with us to try to roll this out. But who's going to pay for this? And that's where it gets complicated because the system doesn't really have a place for this yet. So we're still looking, and we did cost effectiveness, economic evaluations on this as well. You know, you'd be crazy not to pay for this because it's not very expensive, and in the long term, the health benefits and costs are huge as well. But the people who have to pay don't actually get the gain. So we're still puzzling and continuing to do so because we think this really needs to find a better place in the Netherlands. And the predecessor of Eurofit, which was called Football Fans in Training in Scotland, they've been now offering the program for 10 years, paid by the Scottish government, run by the National League in all the Premier League clubs in Scotland. So we hope to get there one day, but it's really difficult. And like I said at the beginning, we have people in our team who are doing implementation science things and really looking at these kinds of things and policy evaluation, how can we make those kinds of changes actually stick, not just doing nice trials, but how can we bring those trials to practice and make sure that they are rolled out and still used over time. Yeah, go ahead.
know what convinced the Scottish government to actually implement the program?
We have very good contacts with our colleagues in Scotland because they actually led this trial as well. I think they were just lucky. I don't know. It's yeah. I mean, we've talked to the ministry about this, and actually there were two guys working at the ministry that were participants at Ouder Den Haag, and they loved the trial. But how to make that happen? It's difficult. And in the end, everybody's excited about it. But to make that step to find the funding, yeah, that's where it gets complicated. Maybe the Scottish people are, you know, I don't know, but we're kind of jealous. We're kind of jealous.
In Scotland, your health
Yeah, the healthcare
insurance
system.
is from the government, right? So they have a direct incentive because by paying for this, they will save.
Yeah, that's probably true. Yeah, yeah,
On
yeah.
your health,
Yeah.
right? Where in the Netherlands, the system.
Yeah,
is different.
the system is different. Yeah, that's right.
Yeah.
Yeah, that's a good point. Yeah.
I can imagine that's a better.
Yeah.
I'm wondering how expensive would this be if the participants needed to pay for it, like to pay for a gym or any kind of sports membership?
So the participants didn't pay anything because they were in the trial.
Yeah.
We calculated cost, it's about 250, 300 euros per person. So in healthcare land, they laugh at those kind of things because it's really low. But you see now that the clubs who are still running it, they actually offer it to their business club people, or they let people pay, or to their sponsors, or let a company pay for their personnel. So you see that even the little bit of funding is already complicates things. So it's challenging. Tico, did you have a question as well?
Yeah, is it just the money? So if you would have the money, it would work, or would there be more barriers?
I think the main barrier is the money, and there is money because clubs are still running it in different ways. And sometimes there's a local sponsor, or all these clubs have. This is not run in the actual football club, but in their maatschappelijke tak, zeg maar. Sorry for the Dutch. And
Social outreach.
they can make the, what did you say?
Social outreach.
Yeah, the social outreach kind of activities that the club does, but they're in a separate part. They're not actually in the professional football club themselves, but they're linked to it. There's a good word for that, but I can't think of it right now. So depending on local circumstances, they can make it work locally. But what they did in Scotland is roll it out across the whole league and the whole country, and then you reach and you can actually use a monitoring system to see if they still deliver what they were supposed to deliver. And all that is what we'd like to move towards, not just the nice initiatives that we have locally. We want to do this national, and that step is the biggest challenge at the moment. All right, I am 1 minute past 5. I think I should finish up. That's it.
That short finish up, but yeah, we had a lot of discussion already. Any other questions?
Can I ask one question?
Yeah, go ahead.
So I have a little bit difficult to get my head around this. So you present sitting or sedentary behavior and physical activity as two different dimensions, or so it seems. So to me, to my simple mind, sitting is just one form of being inactive. So what makes this form of being inactive so special that it qualifies as a different dimension? So can you tell us anything about the mechanisms that make sitting so much worse than or different than other forms of being?
I think they're not different dimensions because they're same the
Or you
of the same
represent it
spectrum.
on a graph with two orthogonal axes, right?
Yeah, sure. Yeah. But in the end, okay, there's a different way to look at it, and that's the whole spectrum of physical activity. You have sedentary, you have light, and then moderate and vigorous. But because moderate and vigorous is such a small portion, it also matters what you do that rest of the day and what the balance is between sedentary and light, and whether there's sort of a balance there. And I didn't show you the bit about standing because standing is related to all-cause mortality as well. So if you stand more, the risk goes down. But you shouldn't stand all day either because there's health risks around that. And it's not the sitting. At some point, I showed you the slide where it said sitting is deadly, but sitting is not deadly. It's the too much that's the problem. So above a certain amount, that's where it gets tricky. And that balance, I think, is what we're looking at. So it is part of the same spectrum, but because there's so little moderate to vigorous part, that's part of people's daily lives, that is not the solution for what we're doing the rest of the day. And in that sense, they operate on different time scales, but they are, in a sense, part of the same dimension. That makes sense? And I think the graph that I showed you where we had sedentary behavior against physical activity with the red all the way to orange and then green, light is the opposite of the sedentary behavior in a way. Does that make sense? So if you only do a small portion of the 16 hours that you're awake on moderate to vigorous, and the rest is sedentary or light intensity becomes the reverse of sedentary. Because if you're not sedentary, you're light. And a little bit of moderate to vigorous. Yeah, so it matters. And that's why it matches nicely, I think, with the guidelines, where it says every move counts, and some physical activity is better than none. And that some physical activity then doesn't just relate to moderate to vigorous, but also to the light spectrum. Yeah?
So you say, basically you say sedentary behavior is on risk and continuum, but then some people and some health promotion actually promote to break up sitting episodes by short periods of standing.
Yeah.
Which in my opinion, if you look at metabolic expenditure, it would be just replacing, let's say, one sedentary for another.
Yeah. Yeah.
So is there any evidence that this is at all meaningful, or is this?
Well, you will not see that in these guidelines. There are some occupational health guidelines where I think that is mentioned, but not necessarily, I think, from organizations like, a national guideline or a WHO guideline. I think the difference between the energy you expend while sitting down or standing is very small, but there is a difference. And a small difference in a large volume can still make huge impact, right?
Yeah. It's breaking it up for, let's say, minutes.
Yeah, exactly. Yeah.
Small volume still.
Yeah,
But there could be other effects, like, local circulation could be totally different.
sure, yeah,
And maybe
true.
that is.
Yeah.
And that would make sitting something really special. It would then be a different variable.
Yeah, true. And you mentioned the evidence around the breaking up of the sitting. You will not find that in any of these studies because these studies ask people what they were doing and then follow them over time, but they only have a sample of 1 week that's sort of representative of what somebody does. And you can't really ask them how much were you sitting and standing. So the studies you're referring to are the lab-based ones where people are actually able to use where an active poll, for example, that we used in the other study. You can see exactly, or you could actually tell them what to do and look at intermediate markers like biomarkers and look at their blood values, for example. There's some evidence that breaking up sitting is good, and then breaking it up by vigorous is better than moderate, and then standing sometimes shows a relationship, but not always. But they're very different studies, of course. And to put those very short-term biomarker studies in the guidelines where it's all about development of disease and mortality is a bit tricky.
And that's why I was wondering whether there's any evidence for, let's say, real world effects.
Yeah, no, and that's the difficulty. It's because it's really hard to measure. And now that we have the activity tracker data, potentially good, but the question is whether a more holistic estimate of your total amount of physical activity, you can imagine that sort of translates reasonably over time, at least on a group level. But what is that the same for the intermittent pattern that you have throughout the day, or is that very dependent on other things? And does that change more of time? I don't know. But it's complicated, and we can't really keep people in the lab until they get sick or die. I think ethics would make an issue of that. Yeah. You go ahead.
I think it adds a little bit on this comment because it's very much focused on health and all-cause mortality.
Sure.
All these guidelines, whereas maybe it's just hypothetical, but maybe it's more important not to focus on all-cause mortality, but on daily life functioning. And,
sure. Yeah.
That matters maybe even more than being well. Also in terms of costs, healthcare costs.
Yeah, no, it's a good point. And I think at the beginning I showed you that slide from the US guidelines with this very long list of the different health benefits.
Yeah.
And all of those are translated into the guidelines. And I focused a lot on all-cause mortality, you're right, and a lot of the early data that comes out of these prospective cohorts is often that because it's an easy outcome, it's a hard outcome, and functioning is a bit more tricky, right? And but it is there, and I think it does matter, and you see that it's part of the guidelines as well. But it's a good point. We shouldn't just focus on the mortality.
You also mentioned that functioning and short-term risk also is not a good drive for behavioral change, right? Is that something you were mentioning before? That risk for cardiovascular disease, for example, is not a very good drive to actually have people change their lifestyle.
That's the last two slides I didn't actually show you because we're out of time. But I'm not going to show them to you now. But in this study, we had people who had a high risk or a low risk of having atherosclerosis. They were actually, they had some imaging done, so we knew what their risk was. And we thought that if we communicated that risk to them, they would respond differently to a lifestyle intervention. With the idea, if you have that extra motivation because you see your arteries are actually clogging up and your risks of getting cardiovascular disease increase, would be an extra motivation to actually do something about it, because suddenly it becomes very in your face that you're not going down the road that you probably want to go. And in the effectiveness of the intervention, we saw that the people with the low risk had a much better effect of the intervention than the people with the high risk. So apparently, it's the people with the high risk already struggle to do this, and the intervention is not enough to help them get over themselves or make it actually happen, because they struggled already, and the people who have the low risk, it's much easier to participate in the intervention. So that extra motivation where you think, okay, it's now in your face, you need to do something, otherwise, you know, this is going to happen, is not enough to make that change. People really need help to actually make that change happen. And I always like the example where we say, okay, a person with diabetes, if you give them medication, you don't just give it to them for 3 months. You give them for their life. And maybe we need to do the same if we want to change people's behavior, and especially the people who need it the most, who apparently really struggle to make that happen. Not just do it for 3 months and then a few follow-ups, but maybe that period has to be longer. And maybe that does have to be some sort of help throughout the rest of their lives.